can see this slide?
Yes.
Baljinder?
Yes,
Yeah.
maybe.
Yeah, okay.
But if you make it bigger onto
Yeah,
slide,
I'll make it big. I'll
yeah,
make it
thank
big.
you.
Yeah. Okay. You can see this, isn't it? Yeah. So
Yes.
okay. I'm Mabel Pereira. I'm one of the consultants at Royal Berkshire Hospital. Good morning, everyone. So I'm the faculty for today to discuss about cervical screening and colposcopy. As Baljinder mentioned, I will I will answer any questions if you may have at the end. Also, if something is not clear, please free to interrupt. I am happy to go over it again. Okay, so let's begin. Basic understanding of cervical screening and colposcopy is very important for all ONG doctors. This is because as a generalist, we are expected to ask smear history and you may have unexpected questions from patients and you have to counsel them appropriately. So I'll be first talking about cervical screening program as an organization, then I will go through colposcopy. So this is the agenda I'll be talking about. So cervical screening program as an organization, then I will talk about cervical screening program referral pathways, followed by practical colposcopy, and I will conclude with colposcopy training and HPV vaccination. So let's begin with the introduction. Cervical screening is one of the 11 population screening programs available in England. It is estimated that cervical screening saves about 5,000 lives per year in England. Worldwide, more than 250,000 people are estimated to have died from cervical cancer in 2012, with mortality rates across the world. In females in the UK, cervical cancer is the 19th most common cause of cancer death, with around 850 deaths in 2016. In females in the UK, it is the 14th most common cancer with around 3,200 new cases recorded in 2016. Cervical cancer accounts for 2% of all new cancer cases in females in the UK according to 2016 statistics. It's good to know about few milestones in NHS cervical screening program. Some of these milestones you might already know. So let's go through it again. In 1960s, cervical screening began not in a systematic way. In 1988, in a systematic way, it was introduced with the introduction of computerized call and recall system. Liquid-based cytology was introduced in 2004. Before that, cervical smears were done on a slide. A common terminology for that was pap smear. 2008 HPV vaccination program began targeting girls aged 12 to 13. HPV triage and test of cure was introduced in 2012. Since last year, primary HPV testing was introduced as primary screening test, and also vaccination for boys aged 12 to 13 began. Let's look at cervical screening program as an organization. You need to remember only 4 organizations which manage cervical screening program: Public Health England, NHS England, quality regulators, we call it SQAS. It is abbreviation for Screening Quality Assurance Service, and Cervical Screening Program Board. Public Health England is overall responsible for all the screening programs. It advises and supports government related to screening program. It also supports local authorities and NHS hospitals. NHS England and NHS Improvement is responsible for day-to-day operations of screening program in terms of commissioning call recall surveys and also supporting colposcopy cytology services related to screening program, besides other departments like sample takers, maintenance of register, etc. SQAS, or quality regulators for cervical screening program, ensures that all programs are safe and effective by monitoring the data on a day-to-day basis. Cervical screening program board manages cervical screening program at regional level. As you know, in the United Kingdom, there are various regions, to mention few, like Southwest, Southeast, East Midlands, West Midlands. Each region has various hospitals coming under this management. This regional cervical screening board meets up regularly, once quarterly, 4 times in a year, and discusses various issues related to cervical screening program at regional level, like colposcopy surveys, cytology surveys, and also they make recommendations if any improvement is needed. This screening board has representatives from various departments, as I have shown in this slide. Representatives from Public Health England, NHS England, SQUAS, cytology service, colposcopy service, sample takers training representatives, GP representatives, and patient representatives. I'm going to talk to you, or take you through a journey. What happens to the patient when she receives an invitation from call recall system for a cervical smear? That will help to understand what exactly happens with patient's journey from the time she receives the invitation and she comes to the colposcopy clinic, and after that she gets repeated reminders for repeat smears according to the colposcopy results. Call recall service system identifies women to be screened from GP database and sends letters to patient and GP practice. Patient calls the GP practice and books an appointment for the smear. This smear goes to the centralized lab. This centralized lab caters to various hospitals in that region. Once that smear is processed, report is sent to the GP call recall system and patient. Call recall system updates that report and also puts up a date in the register when this patient should be called next. Lab will also send the referral and result letter to the colposcopy service if smear is abnormal and needs input from colposcopy service. Once colposcopy patient sends appointment to the colposcopy unit, sends the appointment, and patient attends the colposcopy clinic, it will test, diagnose, and treat depending upon the findings. Once colposcopy is completed, this information goes to the GP call recall system and patient. Patient will get follow-up reminders or recall smear reminders from the call recall system when it is due. This is a busy slide. This is nothing but whatever I just mentioned to you is depicted in a flow chart. I'm not going to go through this flow chart. If you want to know more about it, it is available in NHS cervical screening publications, which is available in Public Health England website. Let's look at the screening interval. You may already know about it. It's important to know because patients will likely to ask this question in general gynecology clinic if they have defaulted. As you know, first invitation is sent at the age of 24 and a half with the aim to have first smear done by the age of 25. Thereafter, it is sent 3 yearly till the age of 49. From the age 50 to 64, it is done 5 yearly. And from the age of 65, it is done only if they have not had smears since the age of 50 or their recent smears have shown abnormal results. This is again a busy slide. I don't expect you to remember. This is basically how cytology labs report the cervical smear after assessing. This is useful for colposcopists and call recall service. Numerical code is given. This numerical code helps for the call recall system to update in their register and send the invitation at an appropriate interval. The description of this report helps colposcopy units to send appointments at an appropriate interval as suggested in the colposcopy program management. I have color coded for explanation purpose. Is not color coded in the original guidance. If you can see the description in the orange color, this is basically low grade dyskaryosis. When it comes to the colposcopy unit knows that these patients should have appointment within 6 weeks. Description in the red letters, in the red color, is basically high grade smears. They need an appointment within 2 weeks as 2-week wait referrals. This slide shows HPV codes. As you know, cervical smears are assessed with HPV testing as primary test since 2019. They are also given numerical codes, which again helps call recall service to update their register. And also description helps to understand the colposcopist, the urgency of appointment intervals. So let's talk about dyskaryosis. You all may know what it stands for. Dyskaryosis is nothing but disproportionate nuclear enlargement with irregularity in form and outline of the nucleus. This also may show hyperchromasia, multinucleation, irregular chromatin distribution, and abnormalities of the number, size, and form of nucleoli. This slide shows how it looks in a cytology lab and histology lab. If you see the upper horizontal bar, you can see first slide is a normal cell with plenty of cytoplasm and a dot in the middle, which is nothing but a small nucleus. As the slide progresses, you can see towards the end, cells are showing large nucleus almost occupying entire cell with minimal cytoplasm, which depicts high-grade abnormality. Likewise, if you see the lower bar, which shows histology slice, first slide is a normal slide showing normal cell with the tiny nucleus and plenty of cytoplasm, which is again categorized into CAN1, CAN2, and CAN3, depending upon how much width of the epithelium is occupied with these high-grade cells. CAN1 shows lower 1/3 of the epithelium is occupied with high-grade cells. CAN2, 2/3 of the epithelium, and CAN3, entire epithelium is occupied with high-grade abnormal cells. If you see the invasive disease slide, you can see the basement membrane is breached and cells are entering the stroma. So this is a slide showing how it looks in a cytology lab. If you can see upper slide on the left side, it is a normal slide with plenty of cytoplasm and small tiny nucleus at the center. If you see upper right slide and lower slide, you can see the cells with a large nucleus. So let's move on to practical colposcopy. I would like to talk about cervical cancer. What is a pathogenesis for this? I'm sure all of you may know that is caused by HPV viruses. Over 100 HPV viruses cause disease in the female genital tract, out of which only few are oncogenic HPV viruses, as I have mentioned in the slide. There are 16, 18, 31, 33, 45, 52, and 58. HPV 16 and 18 cause more than 70% of cervical cancers. Majority of the HPV viruses cause genital warts, out of which 16 and 11 are very important because majority of the time they are responsible for benign genital warts. Almost all cervical cancers, that is 99.7% of them, contain high-risk HPV DNA. It's important to learn about transformation zone. You may already know. I will go through it again just for updating your knowledge about it. And also I'll talk about squamocolumnar junction. You all know that squamous, as you all probably know about squamous metaplasia. Squamous ectropion is nothing but squamous metaplasia. During reproductive age, cervical columnar epithelium, it everts to the vaginal side and undergoes metaplasia under the influence of vaginal acids. This ultimately becomes squamous epithelium. This is an irreversible process. So once it becomes completely squamous epithelium, it has got original squamocolumnar junction and a new squamocolumnar junction. New squamocolumnar junction is always towards the cervix. The transformation is nothing but the new cervical epithelium, squamous epithelium, which has transformed from the columnar epithelium. So it is important to know different types of transformation zone, which helps to manage women with abnormal smears appropriately, especially when treating them. So depending upon the site of new squamocolumnar junction, which is always towards the cervical side, it is divided into three types. If it is completely visible, mostly during reproductive age, as you see in this slide, slide number C, it is on the ectocervix. It is called transformation zone 1. As age advances, especially in perimenopausal age, it recedes towards cervical canal and it is barely seen. So this is called transformation zone 2. And it is shown in picture D. And in postmenopausal women, it completely recedes inside the cervical canal and it is not seen. And this is transformation zone 3. So let's move on to colposcopy examination. Once colposcopy unit receives referrals from cytology lab with abnormal smears, appropriate appointment letters are sent to the patients depending upon the severity of their abnormal smear. And also information leaflets are sent along with this appointment letter. Once they attend the clinic, detailed history will be taken like any other gynecological appointment. Their obstetric history, menstrual history, contraception, previous visits to colposcopy clinic, previous history of an abnormal smears, and general medical history is taken. History of allergies is also important, as some of these patients need local anesthetics for treatment, and iodine should be avoided if they have shellfish allergy. There should be facilities for data recording, which is nowadays recorded on a software, either on EPR or exclusive software is available for colposcopy units. Exclusive software helps in monitoring the data at a regional level and also helps for quality regulators. Clinic also should have facilities for toilets, refreshment area, changing area, and recovery area. There should be policy for visitors, and consent from patients should be taken if students or trainees attend the clinic. Colposcopy clinic will have appropriate adjustable bed. There will be a monitor and printer which helps in teaching and education. Equipments needed for the examination are speculums, vaginal speculums and cervical speculums, swabs, sponge holding forceps, acetic acid, glucose iodine, hemostatic agents like silver nitrate, ferric subsulfate, nothing but Monsell solution, and diathermy machine with smoke extraction facility for treatments. Other equipments may be used in different units like laser, cold coagulation equipment. Most commonly used equipment for treatment is diathermy machine. This is how colposcopy looks. It was developed by German gynecologist Hans Hinselmann in 1925. Is usually used in outpatient setting in the colposcopy clinic. It is also used in the theaters, suppose colposcopy is needed to be done under general anesthesia. These are some of the indications for colposcopy. Commonest indication is abnormal smears. Colposcopy is also done for suspicious looking cervix and postcoital bleeding. Quickly, I just want to mention about referrals for postcoital bleeding. Not all postcoital bleeding patients needs to be seen in the colposcopy clinic. Patients, those whose smear has been normal and clinical examination shows cervical ectropine only, they may be observed for a few months before referring to the postcoital bleeding. Likewise, women, those who are on oral contraception and their recent cervical smear has been normal, they also may be observed for a few months and then referred appropriately. Colposcopy on a rare occasion may be needed for some women, those who have persistent vaginal discharge and clinical examination is suspicious for malignancy. This is how normal cervix looks under colposcopy. In both the pictures you can see columnar epithelium clearly, reddish color with villous appearance, and lateral to that you can see squamous epithelium which is translucent and has pinkish tinge. You also, in the first picture, you can also see this columnar epithelium which has undergone metaplasia and has become squamous epithelium now, which has got whitish areas with pinkish tinge. In the squamous epithelium, which has recently undergone metaplasia from columnar epithelium, also has glandular cells. They won't disappear. So you will see Nabatean follicles on the cervix because of these are mucus filled glands from the columnar epithelium. 90% of the cancers which happen in the transformation zone are squamous cell carcinomas, and around 10% of them are adenocarcinomas, which happens in the glandular cells. These are some of the colposcopy features after acetic acid application. Acetic acid is the important dye which is used used for colposcopy examination. As these abnormal precancerous cells have got increased nucleic acid protein, it absorbs acetic acid and changes into whitish in color. We call it as acetowhite appearance. Depending upon the severity of the abnormality, grade of acetowhite also differs. You can see acetowhite changes in the upper first and third slide. Other features which are seen under the colposcopy after acetic acid application are mosaic pattern, punctations, and abnormal vessels. You can see the upper first and third slide mosaic pattern, which is fine mosaic. Basically, these are blood vessels coming together and forming a pattern there. They're sparsely placed, so it is called fine, which is usually seen in low-grade dyskaryosis or CN1 abnormalities. If you can see upper middle slide, it has got feature which is called punctations. This is nothing but endpoints of abnormal vessels which are seen under the colposcope. Lower slides, if you see, first slide has got mosaic pattern, which we call it as coarse mosaic, which is usually seen in high-grade abnormalities. And lower third slide, if you see, you can see abnormal vessel pattern is called spaghetti type of pattern. It's usually a feature of invasive carcinoma. Lower middle slide, you can see that this slide is suggestive of cervical cancer. You can see there abnormal growth on the cervix with raised edges and abnormal patterns on the cervical growth. This slide shows pictures of squamous metaplasia, nothing but ectropine. You can see columnar epithelium with its reddish and villous appearance, which is undergoing metaplastic changes. You can see squamous epithelium with the pinkish and whitish tinge there, especially in the upper middle slide. So this you will be encountering this type of features when you do regular gynecological examination in the gynecology clinic or day assessment unit in the labor ward or acute gynecology clinic. These are pictures of low-grade CAN. If you can see in the first picture, mild acetowhite, especially in the posterior lip of the cervix. And you can clearly see the squamocolumnar junction there. So this is type 1 TZ. In the picture on the right side, you can see on the lower lip of the cervix, especially mild acetowhite, just adjacent to the squamocolumnar junction. These pictures are suggestive of high-grade CAN. You can clearly see acetowhite areas in all the pictures. In the first picture, you can also see some punctations, especially on the lower lip of the cervix. You can see how it looks after iodine application in the lower pictures with acetowhite, same cervix with acetowhite as well as iodine. You may know why iodine uptake is poor in cervix with CAN features. Normal cervix has plenty of glycogen, so it takes iodine take-up is very good, so it stains brown completely if there are no features of CAN. If there is evidence of CAN, uptake will be poor and it shows as pale or completely iodine negative area. These are pictures of high-grade CAN, especially CAN3. You can see dense acetowhite in all the pictures with the punctations you can see in first picture on the upper bar and lower picture as well. Especially if you focus on the lower picture, you can see clearly all the features of high-grade CAN are there. Punctations, coarse mosaics, and dense acetowhite area. These pictures don't need any explanation. It's self-explanatory. It's clearly suggestive of cervical cancer. You can see abnormal growth on the cervix, ulcerative lesions. Basically, once you have seen this, these patients need urgent assessment in the colposcopy clinic with diagnostic biopsies to confirm the diagnosis. Besides having usefulness in diagnosing cervical intraepithelial neoplasia and cervical cancer, colposcopy at times is also useful in diagnosing benign features. These are some of the pictures of benign conditions which are seen under colposcopy. First picture is cervix with a polyp, and picture on the right upper slides, you can see cervix with the Nabothian follicles. I have already explained about Nabothian follicle, why it happens. It's important to know that Nabothian follicle is a benign finding, doesn't need referral to the colposcopy clinic. If you have this understanding, unnecessary colposcopy referrals can be avoided. If you can see lower pictures on the left side, cervix with red dots. This is nothing but cervix with how cervix looks with trichomonas vaginalis infection. Description for this feature is strawberry appearance. Lower slide, if you can see on the right side, you can see cervix with inflammatory changes, is chronic cervicitis. This is also an important cause for postcoital bleeding. Once cervical biopsies rule out any feature suggestive invasive carcinoma, these patients can be treated with diathermy for their ongoing postcoital bleeding. I'm going to talk about common procedures which are done in the colposcopy clinic. One of the commonest procedures which is done in the colposcopy clinic is diagnostic biopsy. Usually it is done as punch biopsy, and on rare occasion it is done as excisional biopsy. Treatments which, excuse me, are you all okay?
Yes, Mabel.
Okay, because there was some interruption, that's why I was asking. Okay, thank you so much. Okay, so about the treatment, let's discuss few points about this. Most often treatment is done as excisional biopsy. Equipments used are diathermy and laser. Most commonly diathermy is used. Very rarely ablation is also used for treatment purposes. Ablation is usually used for treating CAN1 abnormalities and also ongoing postcoital bleeding because of cervical ectropion or inflammation. Some units use ablation for high-grade abnormalities as well, but you have to be extremely careful while doing ablation for CN2 and CN3, as you may sometimes miss microuniverse cervical carcinoma. Usefulness of excisional biopsy is that specimen is available which can rule out any microinvasive cervical carcinoma, as well as it gives information about completeness of the procedure. So briefly, I'll mention how CAN is managed in the colposcopy clinic and overall management as a cervical screening program. CAN1 doesn't need any treatment. Usually monitoring is needed, and they will have repeat smear in 1 year. Usually by that time it would have resolved on its own. Very rarely CAN1 is treated if patients come back with the persistent postcoital bleeding or abnormal bleeding. CAN2 and CAN3 need close treatment or close surveillance. CAN3 definitely needs treatment with excisional biopsy. CAN2 can be managed conservatively or with excisional biopsy. Most of the units treat CAN2 with excisional biopsy. There are some units in UK, they manage it conservatively. If you manage it conservatively, these patients need regular follow-up in colposcopy clinic with biopsies to rule out that it has not progressed and it has regressed, and they can be safely discharged back to routine call and recall service. CN2 and CN3, when they are seen in the colposcopy clinic, they are managed as see and treat procedures in more than 80% of the cases. Let's look at LEDS procedure briefly, because this is one of the commonest procedures performed across all units in England. More than 80% of LEDS procedures are done under local anesthesia. More than 80% of cases, they are done as see and treat for high-grade smear in one visit. All will have test of cure smear after 6 months. They should avoid sexual intercourse, tampons, swimming for 4 weeks. If IUCD in situ, it needs removing during the procedure. They shouldn't have sexual intercourse for 5 days prior to the procedure. All this information would have been given to them through information leaflets before coming to the colposcopy clinic. Colposcopy is performed by appropriately trained colposcopist, and this training is facilitated by BSCCP, which stands for British Society for Colposcopy and Cervical Pathology. There is a structured program, and it is expected that all colposcopy trainees should keep one electronic colposcopy logbook, which involves direct supervision of 50 cases and indirect supervision of 100 cases. It's also expected that all trainees are expected to attend histology and cytology labs involving 5 hours of each, and also there is an exit OSCE. Colposcopy can also be done as an ATSM. ATM also requires accreditation from PSCCP. Also, it needs attendance at basic colposcopy course. Finally, I will talk about HPV vaccination and sample taker score. You all may know that there are 3 types of HPV vaccines: bivalent, quadrivalent, and nanovalent. Bivalent involves 2 HPV viruses, quadrivalent 4 and nanovalent 9. Nanovalent is the vaccine which is widely used in USA. In UK, we use Gardasil, which covers 4 viruses: 6, 11, 16, and 18. 6 and 11 protects against benign genital warts. Is given at the age of 11 to 13 years, and it is given in 2 doses. Since 2019, it is given both for boys and girls. It prevents only 70% of cancers because it has only a protection against HPV 16 and 18. Since cancer can be caused by other viruses, oncogenic viruses, it will not protect against cancers caused by them. So still cervical screening is needed for all women. Let's look at sample taker score. Once you have taken the cervical smear, it has to be sent to the lab with appropriate description along with a pin code. It's mandatory for everybody who is taking cervical smear nowadays. Without that, labs will not process it. So these are the people who can take sample takers training in UK: registered nurses, nursing associates, midwives, physician associates, healthcare professionals, those who work in the sexual health clinics, and GMC registered doctors. All trainees in ONG can avail sample takers code, take smears, and send them to the lab. You will have to liaise with your colposcopy unit to get the details of these sample takers unit at NHS England, and they can forward your details to them, and they will register in their register, and they will give you a PIN code, and after that you can take the smears, and you can update your training or PIN code once in every 3 years. To update this training, you need to have certification done through NHS e-learning resource, which is available at ELH library. So to conclude, basic knowledge of the cervical screening program is essential to appropriately counsel patients in day-to-day practice. Cervical smear is the most sensitive and specific screening test, and women should be encouraged to have it done as per the screening recall invitation. Basic understanding of the physiological and benign conditions of the cervix helps to avoid unnecessary referrals to the colposcopy clinic. So these are some of the references which may be useful for you if you need further information related to cervical screening and colposcopy. That concludes this presentation. Thank you for listening patiently.